session, so you don't have to wait till the end. So lactose intolerance and cow's milk allergy are often used interchangeably, resulting in inaccurate diagnosis. So it's my aim to go through these two conditions today and help you understand the difference so we can diagnose our children with the correct diagnosis. Because in clinical practice, we do see a lot of children that are diagnosed with lactose intolerance, but in fact, they turn out to have cow's milk allergy. I don't have access or control of the slides. So Vicky, please do you mind going to the next? Thank you so much. So this is just an outline of today's session. We've got quite a bit to cover. So we're going to go through lactose and lactose intolerance. There are 4 clinical types of lactose intolerance, so we'll go through those. Then we'll focus specifically on secondary lactose intolerance because there is a link to cow's milk allergy. And then the benefits of lactose. We'll discuss cow's milk allergy and the MAP guidelines. We'll look at IgE versus non-IgE cow's milk allergy, signs and symptoms of cow's milk allergy, symptoms of lactose intolerance versus cow's milk allergy. So I've done a table just to help you see the difference there. And then we'll just look at some of the specialized formulas used in children with cow's milk allergy. And we've got some case studies where we'll look at a child that was diagnosed with cow's milk allergy, but actually turned out to have lactose intolerance and vice versa. And then how do we diagnose non-IgE cow's milk protein allergy? And then obviously we'll look at some treatments and what happens after one. So let's get going. So I'm Nishti, I'm the founder of Nishti's Choice. We provide online consultations to children and parents all over the world. I'm a registered dietitian in the UK, but also in Denmark. And we do accept referrals from GPs and other healthcare professionals. Next slide, please. We do offer a range of services, so as well as looking at food allergies, which is where most of our clients come from, we also look at children and adults with growth concerns, obesity or faltering growth, or also eating disorders, nutritional deficiencies, diabetes, celiac disease, and a range of other conditions. We have other dietitians in the team that help out. Next slide, please. So what is lactose? So lactose is a disaccharide and is the main sugar found in mammalian milk and milk products. And both breast milk and infant formula provide up to 50% of their total energy and provide up to total of 50% of the energy. Lactose is digested by the enzyme lactase, which I'm sure you're all aware of. And this digestion and absorption takes place mainly in the mid-jejunum, with the highest expression taking place there. Next slide, please. There are 4 clinical types of lactose intolerance. So first of all, lactose intolerance is clinically defined as lactose malabsorption with associated gastrointestinal symptoms. Then we have lactase deficiency, which describes the state of reduced lactase expression. Now, I have got an article to support this presentation today that I think Vicky is going to send out to you all, and I'm hoping that will complement today's session. So the first one, developmental lactase deficiency. So this is observed in premature infants less than 34 weeks of gestation. Low lactose or lactose-free formulas are often used, but because they don't meet the child's nutritional requirements, we do usually use lactase drops with the formula or with breast milk to ease symptoms. Then we have congenital lactase deficiency, which is extremely rare. And this is a result of severe autosomal recessive disorder seen in newborns, and is characterized by severe osmotic diarrhea and faltering growth. And these children require a lifelong lactose-free diet. Then we have lactase non-persistence, also known as primary lactose intolerance. And this is a physiological decline in lactase activity with age. It is very rare in children under the age of 5. It peaks in teenagers and in adults, and usually ethnic origin plays a big role here. Then we have secondary lactose intolerance, and this occurs because of mucosal injury, so resulting from either gastrointestinal illness or enteropathy, such as non-IgE cow's milk allergy. Next slide, please. So secondary lactose intolerance in young children is the most common cause of in children, the most common cause of lactose intolerance include gastroenteritis, but also cow's milk allergy. Lactase, the enzyme lactase is very sensitive to any type of bowel injury or distress, which can cause lower levels of lactase. So for a child with, for example, cow's milk allergy who's had diarrhea, they will most likely also have some type of bowel injury and distress, which can cause lower levels of lactase. And obviously, lower levels of lactase result in undigested lactose passing through the gut, causing symptoms associated with lactose intolerance. Next slide, please. So I just want to talk, there are major benefits of lactose, and we've had a lot of children put on a lactose-free diet or omitting lactose unnecessarily long term. And we need to be mindful of that because lactose has been shown to have several benefits. So for example, calcium absorption, there are few studies to show that formulas that contain lactose can increase the absorption of certain minerals, most importantly calcium, but also zinc. Then we have the benefit on the gut microbiota because lactose is in fact a prebiotic. So the addition of lactose in baby formulas has been shown to increase good bacteria and reduce bad bacteria compared to a lactose-free variant. And then lactose makes formulas taste really good. So if you're prescribing a formula without lactose in, it's not going to be so palatable. However, if you prescribe one with lactose in, it's going to taste better. And we'll go through that a bit later on. Next slide, please. So let's talk about cow's milk allergy because we cannot talk about lactose intolerance and not talk about cow's milk allergy as well. Next slide, please. And if anyone has any question, please let me know. And I hope it's not too quick. I'm just mindful of you all coming on this evening. So MAP guidelines, these are updated 2019, and you can find these online. And I'm going to show you a picture in a bit of a website for GPs that I would highly recommend. You're probably all aware of it anyway. So this is a presentation of suspected cow's milk allergy. So if you follow this flow chart with the children that you see, it should hopefully guide you to an adequate diagnosis. Next slide, please. Because this slide here shows you the management of mild to moderate non-IgE cow's milk allergy in primary care. And it's very comprehensive and it has been updated lately, well, 2019 now. So these materials are all available online, and particularly on the next slide, you'll see a really, next slide, please, Vicky. This slide here, or this website for GPs has all the information that you need for information on cow's milk allergy. It also shows you the diagnostic tool for non-IgE cow's milk allergy, which I will show you later on. And I would highly recommend this website for you all. Next slide, please. So I just want to quickly mention the importance of a allergy-focused clinical history. This is obviously what you all do, but we need to look at a child's growth and history of presenting symptoms. Family history of atopy is so important, and also the medication and response to previous treatments, especially if they've been on a lactose-free formula or if mom has gone dairy-free and it hasn't worked. When you have a child with suspected cow's milk allergy or lactose intolerance, you want to look at their feeding and you want to look at weaning. And you also want to consider validated tests to confirm and exclude allergy, because as we know, for children with a suspected IgE allergy, so immediate allergy, we can do tests for these. But unfortunately, for those with the delayed type of symptoms, which are often confused for being lactose intolerance. These are very difficult to diagnose. The gold standard is an oral food challenge, which we will get to a bit later on. Next slide, please. So the difference between IgE and non-IgE. IgE is an immediate reaction, either minutes or up to 2 hours. It's easier to diagnose because we have validated tests, whereas with the non-IgE mediated cow's milk allergy, it can take between 2 to 72 hours to present. And these are obviously delayed symptoms. It's harder to diagnose. Sorry, that's a spelling mistake. And there are no validated tests except for the IMAP guidelines, which I will show you a bit later on. And if we were to look at the symptoms, which is on the next slide, between the two, you've probably all seen these before. So they affect the gastrointestinal, so cow's milk allergy affect the gastrointestinal tract, skin, and the respiratory tract. And it's quite different from a child presenting with IgE versus non-IgE. It is usually very clear if a child has IgE allergies. They will have immediate vomiting, and they can still have diarrhea, abdominal pain, and colic, which is very similar to the non-IgE presentation. These children, however, you will also find mucus in the stools, abdominal pain, perianal redness. Then you've got children with non-IgE. We often hear parents say, it's like they have hay fever-like symptoms. So sneezing, runny nose, nasal itching, shortness of breath, wheeze. And as I said, parents describe these as hay fever-like symptoms, whereas in IgE, it's acute rhinitis. And then you've obviously got the very classical symptoms of an IgE allergy: immediate swelling, redness. You can also get redness and itchy skin in non-IgE, but these will be delayed symptoms. And with your IgE signs of anaphylaxis, which you will not see in your non-IgE population, but you will see faltering growth. However, I will just say that majority will actually have normal weight, but that doesn't mean that they don't have a non-IgE cow's milk allergy. We do see a lot of parents who've been told their child don't have an allergy to cow's milk because their growth is fine, but they're presenting with various other symptoms. And particularly even atopic eczema. I just want to mention that we see a lot of children who have been prescribed steroid creams, but in fact, it turns out that they had cow's milk allergy all along. So if you have a child with atopic eczema and or any of the other symptoms associated with non-IgE cow's milk allergy, it would be always good to think, could this be a delayed allergy to cow's milk or not? Next slide, please. So this is when it gets interesting. So symptoms of lactose intolerance versus non-IgE cow's milk allergy. And I'm focusing on non-IgE cow's milk allergy because this is what's often confused as being, often missed and labeled instead as being lactose intolerance. So you can see here the first 1, 2, 3, 4, 5, 6, 7 symptoms are, or 5 to 7 symptoms are fairly similar between the two. But then you've got symptoms that really do differentiate cow's milk allergy from lactose intolerance. You will see children with loose stools and who have cow's milk allergy and or lactose intolerance, abdominal pain, colic, excessive flatulence, nappy rash. Constipation and vomiting, though, is very rare in children with lactose intolerance. And when I'm talking about lactose intolerance, I'm referring back to secondary lactose intolerance, because lactase non-persistence or primary lactose intolerance is very, very rare in children. I think in 15 years, I've only seen one child with that condition. So when you have a child with loose stools and abdominal pain and colic, then yes, they could have lactose intolerance, but they could also have cow's milk allergy, particularly if they also have any of the other symptoms that are associated with non-IgE cow's milk allergy. And this is where referring back to the MAP guidelines would be really helpful for you all. Next slide, please. So lactose intolerance affects the bowels only. So if you have a child with atopic eczema and loose stools, then perhaps it is pointing towards maybe cow's milk allergy more so than lactose intolerance, because non-IgE will affect, as I said, the gastrointestinal tract, skin, and the respiratory tract. Lactose intolerance is not an allergy. And usually after 4 to 6 weeks of excluding lactose, the child should be okay again, because lactase enzyme will be growing back again. Whereas with cow's milk allergy, we exclude dairy for 4 to 6 weeks, followed by a reintroduction to confirm or exclude allergy. The dietary advice for lactose intolerance is lactose-free diet, because a lactose-free diet is free from lactose. But if a child has non-IgE cow's milk allergy, a lactose-free diet will not be suitable, because lactose-free products still contain the cow's milk protein. So it may not have lactose in, but it still has the protein, the trigger for an allergy. Next slide, please. So in very short terms, cow's milk allergy is an allergy and lactose intolerance is not an allergy. Next slide, please. So the specialized formulas used in cow's milk allergy, we've got extensively hydrolyzed or amino acid formulas, and these are shown on the next slide. So I just want to talk about these and also just mention why it's important to know what, whether they contain lactose or not. Next slide, please. Because I'm sure you're probably all aware that extensively hydrolyzed formulas still contain cow's milk, but the protein has been broken down into smaller peptides, whereas amino acid formulas are completely free from cow's milk because you only have the amino acids. And amino acid formulas are usually, well, they are all lactose free, whereas extensively hydrolyzed formulas, some contain lactose and some don't. And this is where it can get a bit confusing. So I'm hoping to help you out a little bit today by giving you an overview. So if you go on to the next slide, please, Vicky, thanks. So the Nutramigen range, they don't contain any lactose, whereas the Aptimal Pepti and Althera range, they contain lactose. So if you have a child with suspected non-IgE cow's milk allergy and loose stool, so maybe they have cow's milk allergy and lactose intolerance, secondary lactose intolerance, if you were to prescribe Nutramigen, because it doesn't contain any lactose, brilliant. But if you were to prescribe Aptimal Pepti, but they have diarrhea, and we actually had a patient yesterday with presenting exactly how I'm prescribing this or describing this, she was prescribed, or her child was prescribed Aptimal Pepti, despite being having severe diarrhea. And that's why there was no symptom resolution, because the lactose is still present. So we may not have the cow's milk protein there, but we still have the lactose. So if you have a child with suspected non-IgE cow's milk allergy, always consider whether the formula contains lactose or not, because if it does, then it could result in no symptom resolution. And we see this, this is very standard, we see in our practice. The only problem is they taste much better. So Nutramigen tastes not very good. And then Aptimal Pepti and Althera, they taste really good. And that's because of the lactose. So if you have an older child, let's say 4 months, and they have been diagnosed with non-IgE or suspected non-IgE, and they have loose stools, they may not take to Nutramigen. So this is where I would still prescribe one of the extensively hydrolyzed formula. But if they have, for example, eczema, I wouldn't. If a child has eczema, as per guidelines, I would prescribe an amino acid formula. So it depends on the severity of their symptoms. So symptoms and age, because not every child will want to have Nutramigen, particularly if they're older, because it doesn't taste very good, unfortunately. Next slide, please. So all the amino acid formulas are lactose free. However, they're also more expensive. So if we don't need to prescribe these, we won't. So if a child, as I said, has loose stools and mild non-IgE symptoms, I will still try an extensively hydrolyzed formula with lactose in and see what happens. But if there is no symptom resolution, then we would have to try an amino acid formula. And actually, Neocate, for example, tastes quite good, whereas you're going back to Nutramigen, unfortunately, doesn't taste very good. So there are so many things to consider. So I can understand how it can be a little bit confusing to know which formula to prescribe and which one not to prescribe. Now, if you have a child with non-IgE cow's milk allergy and they have loose stools and you prescribe a lactose-free formula, you might see that the symptoms of loose stools will resolve. However, the other symptoms may not resolve. And I'll show you a case study a bit later on explaining just that. Next slide, please. Yeah, so we do have soya. I must admit, I never really prescribe soya formulas because 60% of children with non-IgE cow's milk allergy will react to soya. So in my experience, whenever we've prescribed soya, it hasn't worked. So I just don't bother, but it tastes good. So that's another option for you. If the child is over 6 months of age, it's more palatable, and it's also available over the counter. But it's a high percentage of children will still react to soya, unfortunately. Next slide, please. So here's a case study, and this is one of our patients. So growth was fine for her, and she was on no medication, no family history of any allergies. Initial symptoms that she presented with was diarrhea, abdominal pain. She was colicky. There was no vomiting. A stool sample was sent for query rotavirus. That came back negative. She was changed from Kendamil to SMA-Althera by her GP. There was no symptom resolution 6 weeks into changing the formula. So we saw her and we suspected that she probably had or had secondary lactose intolerance. So we changed her to Aptamil lactose-free because she didn't have any other symptoms suggestive of non-IgE cow's milk allergy. So as you can see, diarrhea, abdominal pain, no vomiting. So that's a big cue. It does sound more like a case of lactose intolerance because it's only the bowels that are affected. So we changed her over to Aptamil lactose-free and there was complete symptom resolution. But she was also advised to go back on Kendamil after 4 weeks. And I am very up for getting children off formula as quickly as possible. If they don't need specialized formulas, we will not prescribe it. So she was advised to go back on Kendamil, 1 bottle at a time. And after 4 weeks, the lactose-free formula was completely stopped. And diagnosis turned out to be secondary lactose intolerance. So here, what could have happened is perhaps she could have been prescribed Neocate, right? Because there was no symptom resolution. But then we're looking at a 25-pound tin for something that probably wasn't needed anyhow. And we see this a lot in clinical practice. So, if we have to be mindful of what part of the body is affected. If it's mainly the bowels, perhaps it is secondary lactose intolerance and it will resolve over time. But if any other part of the body is affected, then perhaps it is non-IgE cow's milk allergy. Okay, next slide, please. And this girl, so she was second centile for weight and 9th for length. She was on omeprazole and there was a family history of allergies. So mom has IBS and dairy products trigger her. Her initial symptoms were that she was unsettled. So this is often something you will hear parents say. She's not settled, she's crying, she's arching her back in pain. Mucus and loose stools, hives, reflux, and bottle aversion. Now this is, if a child has bottle aversion, I usually suspect there must be some type of allergy present here. So she was changed from hyporganic to optimal lactose-free. Her stools improved, but she became constipated and she remained unsettled. And she still continued to struggle with mucus-filled nappies, bottle aversion, and the hives persisted as well. So we changed her over to SMA Althera. And all her symptoms resolved, and her weight also improved. But we are also very aware that we need to diagnose that this is actually an allergy to cow's milk. So she was challenged on cow's milk formula 6 weeks in, and she became symptomatic again. So this confirmed non-IgE cow's milk allergy. Okay, next slide, please. So how do we diagnose delayed cow's milk allergy? I know a lot of GPs are aware of how to do this now, because given the new guidelines on it, but I just wanted to mention it again. And also it is on the website that I showed earlier on. And I usually go through this with patients immediately, because I want to set the expectations from the start that we have to diagnose that it's actually an allergy. So next slide, please. So this is the guideline, the early home reintroduction to confirm the diagnosis of cow's milk allergy, and it's only for those with suspected non-IgE cow's milk allergy. And on the next slide, you will see that the protocol. So 30 mils day 1, 60 mils mixed cow's milk formula with the hypoallergenic formula on day 2. If I have a child with mild cow's milk allergy or suspected mild cow's milk allergy, I will say change the whole bottle immediately. So it really depends on who I'm working with, and also on parental anxiety levels. But this is extremely important because we want to diagnose it so we don't prescribe formula unnecessarily. Next slide, please. And for those that are breastfeeding and who have suspected cow's milk allergy, obviously we encourage a dairy-free diet for 2 to 4 weeks. And then we ask mom to add dairy back into her diet. And the amount, well, it could be as much as they want. So the IMAP guidelines say mom to just have what she usually used to have in terms of dairy products. And this, again, would help to confirm or exclude cow's milk allergy. But it's very important to understand that cow's milk, the protein from cow's milk can pass from mother to baby. And therefore, if non-IgE is expected in a breastfed baby, then they have to go on, mom has to go on a dairy-free diet for 2 to 4 weeks, not lactose-free diet, because remember, breast milk is mainly made from lactose anyway, so we can't exclude that. And then we need to also advise mom to take calcium supplements or increase the calcium in her diet. And we usually advise mothers to go on to fortified oat milk because, again, soya and the cross-reactivity with cow's milk protein, there's just no point. So we usually advise oat milk first. Next slide, please. And I think I've explained this already. For formula-fed infant, you will do 2 weeks and then trial extensively hydrolyzed formula for 2 weeks. Now, what we can also do at times is try an extensively hydrolyzed formula for 2 weeks. If symptoms haven't improved and they have suspected mild non-IgE cow's milk allergy, you may try another extensively hydrolyzed formula before you prescribe an amino acid formula. Unless the child has really severe atopic eczema, you would, as per guidelines, go on to an amino acid formula. But I think it's good to play around with the extensively hydrolyzed formula category first, because we do find that often we jump from extensively hydrolyzed formula directly to amino acid formula, but sometimes it's actually about playing around with them because they all are different. And for example, there is also now, and I didn't show you that because there's just so many, there are some that contain probiotics. So if you have a child that is struggling with their bowels, for instance, you could prescribe an extensively hydrolyzed formula with probiotics in. So playing around with that category in suspected mild non-IgE cow's milk allergy, I would advise that before you move on to an amino acid formula, just to avoid everyone going on to Nucate. Next slide, please. So once cow's milk allergy is confirmed and the child is better, then we advise a cow's milk-free diet for 9 to 12 months, until 9 to 12 months of age, or at least for 6 months. And the guideline to support this, or the evidence, is poor, but that's how we work in practice. And then obviously refer to a dietitian with help with milk-free weaning. And then we advise to commence the milk ladder from 9 months of age. For children with mild non-IgE cow's milk allergy, I would advise them to start from 9 months. But for those with more severe type of presentation, especially atopic eczema, we find that it takes a little bit longer. So we'll wait till 1 year of age, but it's often it takes them a little bit longer to outgrow their allergy. But we are very proactive with introducing food allergens into the diet in the meantime. And as soon as we can move on to the milk ladder and off formula, we will do that. Next slide, please. So I stopped the formula from age 1. And that's because unless the child has dropped weight and is not feeding very well, which, you know, it's quite rare to have this type of child. But if a child is weaning well, but they're loving their formula, I advise mothers, and I do that from sort of 10 months of age, just to set the scene and the expectation and say, okay, from 1 year of age, you can stop formula milk and you can go on to a plant milk, such as oat milk. So we are already telling them this is what's going to happen. And from 1 year, you can start adding a little bit of oat milk in with the formula and slowly wean them off it. They're very reluctant to go off formula. It's often a battle to get them off formula. But no child needs formula past 1 unless there are any nutritional concerns. And then have they started the milk ladder? If not, then actively encourage parents to start. And then obviously we need to make sure we have introduced the food allergens in the meantime. As per guidelines, actively exposing children to all the food allergens as early as possible. Next slide, please. And I'm sure you've all seen the milk ladder. It used to be 12 steps. Now it's 6 steps. And I usually add another step, so 6.5, especially when you go from pancake to cheese. I advise parents to do cooked cheese first, but it actually really depends on the child and who I'm working with and the parents and anxiety levels. So there are so many things to consider. But the website that I showed earlier on for you all, it has all the information on there. And I'm sure you all ask parents to have a look at the milk ladder, but ideally they should commence the milk ladder with the help of a registered dietitian. Next slide, please. So really what we discussed was that lactose intolerance is most likely secondary to mucosal injury, resulting from either a gastrointestinal illness or enteropathy, such as non-IgE mediated cow's milk allergy. I think 8 out of 10 referrals are often written as this child has suspected lactose intolerance, when in fact it's cow's milk allergy. Lactose intolerance is very rare in children, and if it is present, it's most likely because of diarrhea, because of their non-IgE cow's milk allergy. Given the many benefits of lactose, it is recommended not to eliminate lactose for longer than required. So some families will be on lactose-free formula for a very long time when they don't need to be. Lactose intolerance should resolve, if it's secondary lactose intolerance, it should resolve after no longer than 6 weeks, and then the child can go back on normal cow's milk formula. So for infants with loose stools, a lactose-free formula may be required at first, but not for longer than 6 weeks. And if no resolution is seen, then please consider cow's milk allergy. Thank you so much. Am I within time? Oh yeah, I am. Any questions? I hope you have some questions.
Thank you, Nishti. That was a brilliant talk. Thank you. If anyone's got any questions, if you want to take yourself off mute and ask Nishti, that would be absolutely fine. I'm just going to pop a link to the feedback survey in the chat function now. So if you have any questions, sorry, if you can leave your feedback, it will literally take a couple of minutes, and that'd be really helpful for both myself and for Nishti.
I think Nazir has a question.
Yeah. Sorry.
Oh, hi.
Yeah, hi, Nishti. So nice talk, very beautiful talk. Yeah, made it clear. But I have got one question. You said that the most of the kids are having the lactose intolerance, isn't it?
Most of the kids that are referred to us on the referral letter, it says suspected lactose intolerance, but actually when you look a bit closer, it's secondary lactose intolerance, which most likely was to do with them having cow's milk allergy, but because a child with cow's milk allergy who has loose stools can have secondary lactose intolerance as well. Does that make sense?
Yeah, that's right.
And this is where it gets a little bit confusing, but it doesn't mean that they have lactose intolerance, because yes, it does mean they have temporary lactose intolerance, but it's not lactase non-persistence, which is, the primary lactose intolerance. Yeah.
Okay. If somebody is child is having gastroenteritis and following that, the child develops lactose intolerance.
Yeah.
Would you qualify that as allergy or secondary?
I would, unless they have any other symptoms affecting the respiratory tract or the skin, then no. I would suspect that that's a child with secondary lactose intolerance.
Fine. Thank you.
Yeah. Thank you. Thank you so much, everyone.
Do we have any other questions?
We see children on lactose-free formula they're prescribed lactose-free formula for months. They don't need that. So I think we can definitely improve on that. I mean, formulas are just overprescribed, as we know. And children being on Neocate for absolutely no reason. And yeah, there's plenty of work we can do there. The parents won't stop. Yeah, that's right. I often say this line to parents. I say, yes, I always validate their feelings. We have to do that, don't we? And then I say, okay, the nutrients from food are more important than the nutrients from milk. And we don't want any nutrient interaction, because we all know that obviously, although there's poor evidence to support this, but we know that too many nutrients is not going to be good for the body. And we want the nutrients to come from food. So that's the line I use with parents. I say, nutrients from food are more important than nutrients from milk. Milk, you need iodine, you need calcium and B1, B2, vitamin D, but you can get that from a fortified oat milk. So we need to stop the formula. Easy said than done.
A couple of comments there for you, Nishti. No need for questions. Beautifully clear talk. Really useful talk. Thank you.
Thank you. Thank you so
Thanks
much.
for the lovely talk. So yeah, I think I'm not sure if there's any more questions. There's no one has typed anything in the chat, but yeah, sorry, Nishti.
Yeah, if anyone wants to have a chat, I'm a private dietitian, and I'm open to work with any of you. I don't know if there's anyone here that works privately, but very open to a collaboration.
Okay, brilliant. If you have any other topics that you think may be useful, Nishti is certainly very keen to come back and talk to you. So if you want to pop that in your feedback, and hopefully we'll arrange some future talks with Nishti. So
thank you so much. Thanks for taking time out on this Thursday evening.
Hey, thank you very much for joining us this evening, and thank you for the lovely talk. And I'll see you all soon.
Thank you. Bye.
Bye.
Bye.